Good afternoon, everyone. My name is Dr. Anushree. I am a neurology resident in Apollo Hospital, and we have Dr. Sudhir Kumar sir with us, who is senior consultant neurologist in Apollo Hospital. So today we will be addressing a few questions that patients commonly have in relation to brain stroke, specifically in relation to diabetes, how diabetes is related to brain stroke, and how we can prevent and treat both the conditions. Good afternoon, sir.
Good afternoon.
The first question is brain stroke or paralysis as commonly called, or cerebrovascular accident as we call it. So what are the risk factors for stroke and how important is diabetes among those risk factors?
Yes, I think today it's a very important topic we are going to discuss, and that is the relationship between diabetes and stroke and how we can take care of diabetes to prevent stroke. So just a few words about stroke. So stroke is commonly called, as Dr. Anushree has told, paralysis, where usually one side of body gets paralyzed, and it is among the top 3 leading causes of disability as well as death in world as well as in India. And once somebody gets a stroke, the life is disabled, the family gets affected, and the earning also of the affected member gets affected, and so it's not a good thing to have. So that is why if we discuss about the prevention of stroke, it is always better for us. And if you look at the common risk factors for causing stroke, diabetes other than high blood pressure and high cholesterol. So these are the top 3 risk factors which are also called as modifiable risk factors of stroke. So diabetes is the risk factor for first ever stroke also, and also for the stroke recurrences. And if you look at the types of stroke, as you know, there are 2 types of stroke. One is called ischemic stroke, where the blood supply to brain gets affected, it gets blocked, and for that kind of stroke, diabetes is the important risk factor. The other type of stroke, which is called brain hemorrhage or the hemorrhagic stroke, there the blood vessel ruptures and the blood leaks out. For that, high BP or the high blood pressure is the main risk factor. Diabetes is not so a risk factor for causing the brain hemorrhage.
So, most of the stroke patients that come to emergency have high blood sugar values. Like even when they test at home with CBG machines or in outside nursing homes, sugar levels are high. So does that mean that all of them have diabetes?
Yeah, that's another important question, because when patients come to the emergency room with acute paralysis and strokes, we always check the blood sugar. And if you look at the large series of stroke patients who come to emergency room with first ever stroke, almost 2/3 of them can have high blood sugar. So does it mean that almost 2/3 of people are having diabetes? It is not so, because in acute stroke there are other mechanisms also which can raise the blood sugar, and that is called as stress induced hyperglycemia. So any kind of stress, whether it's a disease of the brain or any new disease, can cause sugars to go up. And also in that time we have various hormonal mechanisms in the body like catecholamines and cortisol, glucocorticoids. So they are increased in the blood, and they also increase the blood sugar level. So generally we can say if about 2/3 of patients have high blood sugar, about 1/3 or half of them may be having actual diabetes, others may be just stress induced hyperglycemia.
Yes, sir. So you have just told us that sugar levels will be high after stroke. So in a patient, in a hospitalized patient, what should be the target blood sugar levels?
Yes, so I think one is the target blood sugar level, and before that we can also say how we can identify whether somebody's blood sugar that was high in the emergency, whether it's a stress induced hyperglycemia or whether it is a diabetes. So we can do a simple blood test called as HbA1c, which is a short form of glycated or glycosylated hemoglobin, and that gives an average blood glucose levels for the previous 8 to 12 weeks. Now if that is high, if we get that level as say more than 7, then we can surely say that this person has diabetes. Whereas if we just look at one single blood glucose level, we are not sure. Now coming back to your second question, when you said the target, so then there is a range. We need to maintain the sugar levels between 140 milligrams per deciliter up to 180. Now that range has been given in almost all the standard international guidelines. The reason is that if we go very strict, then there is risk of hypoglycemia or the low blood sugar. And if we keep the sugars more than 180, then high sugar also is not a good thing for stroke patients. So I think we can aim for 140 to 180, especially in the first 24 hours after stroke.
And how are the outcomes in stroke patients with diabetes and without diabetes?
That's a very good question. So diabetes is not only a risk factor to cause stroke, but people who have diabetes, even the outcomes are not so good. So what are the kinds of outcomes we are looking at? So one is, when somebody has come in with the stroke, the first thing we want to do is give them the clot buster drug or the thrombolytic therapy, where patients who come in the first 4.5 hours, there is an injection we can inject in the vein, and that through the blood it goes to the area of clot and it lyses the clot, dissolves the clot. Now that success of that thrombolytic therapy is less effective in people who have diabetes versus those who don't have diabetes. Other thing we are worried about in a patient who receives clot buster drug is the risk of bleeding, because some patients, like up to 4 to 5% of patients who receive this drug, can have hemorrhage or the bleeding complication due to the drug, and that risk of bleeding is also higher in patients who are diabetic. Now, okay, patients who are not thrombolized, does diabetes affect outcome in them? The answer is yes. So diabetics with stroke, they have a average length of stay which is longer. So they need to stay in the hospital for longer time. Their stay in the ICU also gets prolonged. So they generally 1 to 2 days extra they need to stay in the hospital. And if you look at other complications of stroke, like we are worried in the first few days, as you know, we have seen patients where the infarct size increases, the brain swelling also increases. Now these kind of complications, the brain swelling and the infarction, the size of clot increasing, again those things are more common in people who have diabetes, especially if the diabetes is not under good control. And then if you look at other complications, in the ICU patients many times they require ventilation, and we have seen some of them can get pneumonias, risk of infections like pneumonias, urinary tract infection. Now these infections are also more common in diabetics. As we all know, diabetes reduces the immunity, and so they have higher risk of infection. So risk of infection also is more in diabetics as compared to non-diabetics. And then we look at the after discharge, what can happen. So post discharge we are looking at, one is the disability, and normally we look at a score, as you know, it is MRS, modified Rankin Scale score, that tells us how independent the patient is. They are able to do their daily living things like taking care of self, bathing, brushing their teeth, dressing, and walking. Now this kind of independence, functional independence at the end of 3 months after stroke, it is more in non-diabetics, and they are less independent if they are diabetic. And finally, not to forget the death rate, because as I mentioned, stroke is a leading cause of death. So diabetes patients with stroke, they have a higher risk of death as compared to non-diabetics. So as we can see, throughout the spectrum, the diabetics have little adverse outcomes as compared to non-diabetics in stroke patients.
Yes. One other thing that we are scared about, other than disability and death, is recurrence of stroke. So how is the risk of recurrence in diabetic patients with stroke?
Yes, so when somebody gets a stroke, they have a higher risk of getting second stroke also. If somebody gets a second, the risk of third stroke is also there. Now we need to reduce that risk. So one thing commonly we do is, all these patients are put on blood thinners, that is antiplatelet agents like aspirin or clopidogrel, and other is statins. So these two drugs are known to reduce the risk of future strokes. But in addition to that, we need to control the risk factors. Like if somebody has high BP, BP should be kept below 130/80. Similarly, today we are talking about diabetes. So the diabetes also needs to be controlled. If diabetes is uncontrolled, even if we give blood thinners and statins and BP is normal, they can still come with a recurrence. So to prevent recurrent stroke, we should control sugars. And one of the things we can look at is HbA1c, and keep the HbA1c below 7, that is the target recommended. We should not go for very strict control. And if someone is looking at, say, fasting blood sugar, we can aim for about 80 to 120. And after meals, the blood sugar can be aimed at around, say, 140 to up to 160. So we are not going very strict, because some of the diabetics can have, as I mentioned, a risk of hypoglycemia, and low blood sugar can also damage the brain nerves.
Yes, most of the stroke that we discussed till now is ischemic stroke. So you already mentioned that there's another type of stroke, hemorrhagic stroke. So how important is diabetes in hemorrhagic stroke?
Yeah, so people have tried to look at whether diabetes increases the risk of hemorrhagic stroke or not. So most studies have shown either no correlation or very mild correlation. So high sugar is not a risk factor for brain hemorrhage. As I mentioned, high BP is a risk factor. But other than that, so we look at all the complications. So same thing in hemorrhage also, the initial bleeding may be small, and about 38% of patients with brain hemorrhage, the hematoma size or the bleeding size increases in the next 24 to 48 hours. And it has been found that people who are diabetic, the hematoma increase is more in diabetics than non-diabetics. Second thing we look at is the edema, the brain swelling around the bleeding part in the brain. That edema again is more in people who are diabetics. And again similar things, so the length of stay, the risk of death, and the amount of disability. So all these things are more in diabetics as compared to non-diabetics in terms of brain hemorrhage also. Similarly, risk of infections. So other things will be definitely more in diabetics, except the risk of hemorrhage and the repeat hemorrhage. It may not be affected by diabetes.
Yes. And I think the most important question is, what are the non-drug measures to treat diabetes and also prevent diabetes?
Yes, I think today we rely on pharmacological therapy or the drugs, and we all know that to treat diabetes there is insulin. We have many tablets are there, so they are wonderful and they definitely help. But we should not forget the lifestyle modifications, which should be the cornerstone for a patient with diabetes. And in that mainly we talk about lifestyle modification, means mainly the exercise, and the other is the diet. Exercise, as per the WHO guidelines, what is recommended is 150 minutes of exercises, moderate exercises per week, which can be split into 30 to 40 minutes on 5 days in a week. And that can be walking, brisk walking, running, jogging, cycling, swimming. So whatever one likes, or strength training, yoga. So whatever a person likes, but we need to be consistent, so they should do it. Those who are overweight, they need to do little more because they also need to lose weight. So, but minimum recommended is 30 to 40 minutes and about 150 minutes of exercise per week. And other than exercise, there is a role of diet also. So in diet, definitely doctors and the dietitian will give you a diet plan which is called as a diabetic diet. Basically, it is low in calories and little high in proteins. So low, we have to the diabetic should consume, they should maintain a negative balance. So the calorie consumption should be either equal to the calories burned or lesser if they are overweight. And then in the diet, few other strategies also have been tried. And one of the popular things in the recent years is intermittent fasting. So in that, the basic idea is to have extended periods of fasting. So somebody can do, say, more than 12 hours of fasting. That is called intermittent fasting. So they can have a eating window of, say, 8 hours or 10 hours. Again, you should consult your physician and the dietitian before you embark on these strategies, because diabetics have a risk of, as I said, low blood sugar and hypoglycemia. So they should be done on supervision. So lifestyle modification, including exercise and diet, is the key, and not to forget the sleep. So it has been found that people who sleep less, say less than 6 hours every night, the diabetic control is poor, and they tend to overeat. You will remember that whenever you are staying up late in the night, the craving comes, and you keep going to the kitchen and open the fridge and keep consuming extra calories and snacks, and that can push the sugar levels up. If you are stressed, reduce your stress, because stress also can increase the blood sugar levels. So these things are side by side, we have to carry on along with the medications. There is a concept now that type 2 diabetes, many of them can be reversed, but if diet and exercise are not enough to keep your HbA1c normal, then don't feel shy or don't hesitate to take medications. They are all safe medicines, and you must take medications as per your doctor's advice.
Yes. I think to summarize, both stroke and diabetes are preventable and treatable conditions, and we have to maintain our lifestyles, be compliant to medication, and maintain HbA1c less than 7. So if you have further queries, you can book an appointment with Dr. Sudhir Kumar sir, and the link is in the description. Thank you.
Thank you.